Let's get started. Thanks to Dr. Jasandi for being here. So Dr. Jasandi is the professor and vice chair of education at the Department of Emergency Medicine and our assistant dean for academic advising. He is former program director at Northwestern and was a resident and chief resident at Stanford as well. And proud to call him my number one mentor. So I appreciate that he's here. And he's going to give us a great talk on how graduate medical education can combat health misinformation. I'm William Dixon. I'm a clinical assistant professor at Stanford as well, and I have Dr. McLean here, and we are the two new Core Connects chairs for this year. So thanks for being here.
Well, thanks for having me. It's nice to be back to court. I was a board member proudly for many years back in the day. And though it's a small group, I recognize everyone here. So thanks you all for coming. And that makes it kind of fun. So as we go through today's talk, just unmute, ask me questions. We can have discussions and hopefully we'll have some time at the end for some questions. So let's get started. Thank you, William, for number one mentor. That was pretty great. All right. How can graduate medical education help combat health misinformation? It's kind of a niche topic, I think, for Cord Connects, but hopefully you'll get something out of this, both in terms of things to think about, but also practical skills to teach your residents. So with that, I have no disclosures. I do have a disclaimer that some of the things I'm going to talk about today may feel a little political. So these are my views and certainly not those of Stanford. I also want to acknowledge my team. So this is a group of colleagues who have been working together now for, I don't know, 4 or 5 years on this topic. Alex is the PD at Brown. Mike's vice chair of education at Rush. Robert is a professor of nursing at Missouri. Seth at Northwestern, and Lauren at Bay State. And we obviously have published a paper on the exact same title as my talk today, as well as a few others, and continue to do more and more in this area. And I'll just acknowledge that some of the work that's going to be discussed today comes out of this paper. So I do want to say hello to my team. All right, so today we've got 3 questions that I hope to answer, then save some time at the end for your questions. The first is, why are we here at all? So what is the impact of health misinformation? Why is it important? I do want you to walk away with some skills. We're going to talk about best practices for addressing misinformation in the clinical setting that you can try out later today and role model for your residents in the emergency department. And then, the meat of this talk is really why we're doing it in a GME setting, is why support and how to best support our residents who are interested in either being advocates in this space or doing research in this space themselves. So let's get to question number 1. What is the impact of health misinformation? And, I'll start by trying to define misinformation. And, in misinformation, I'll say, has a long and storied origin. Probably we've been misleading and lying to one another as soon as humans could be in communicating with one another, not just even verbal communication. We've been lying all through our history. But, the word misinformation probably came into my consciousness back in 2016. If you'd asked me the word misinformation prior to 2016, I could have defined it, but I'm certain that I had never used the word in my own speech. But in 2016, you may remember, in August, the first year of the first Trump administration, Kellyanne Conway went on Meet the Press with Chuck Todd and coined the term alternative facts. And there were some scientific information, political information being discussed at the time, and all of a sudden that scientific information also had other information that perhaps was just alternatively as valid as the actual scientific information itself. And there began what became more and more concerning rhetoric, on both sides of the aisle, but particularly following this Kellyanne Conway comment around alternative facts and getting us to use the word misinformation in popular press. So to define it, misinformation is false or misleading information that is spread without malice. So for instance, if your grandmother was watching Fox News in the morning during the last election, and she saw that Haitian immigrants had been eating cats and dogs on the streets of Springfield, Ohio, and then later that evening at dinner told you about the cats and dogs being eaten, that's misinformation. She was just telling you what she heard on Fox News earlier that day. She wasn't trying to mislead or inform you. She was just spreading what was false information that she had heard earlier in the day. That is misinformation. And health misinformation in specific has been affecting emergency physicians for many decades. We can look at the opioid crisis, vaping, gun safety, reproductive health care rights. These are all health misinformation topics that are very important to emergency physicians. But I'm going to use the example of COVID misinformation just to illustrate the impact that health misinformation has on human health and the public at large. And that's because we just all lived through this pandemic, and we can really, I think, relate to some of the data that I'll use as an example. So COVID misinformation is false or misleading information about the origins of the virus, farcical treatments, and the life-saving vaccine. And we know that in communities who were more apt to believe misinformation related particularly to the vaccine, that vaccine hesitancy or your reluctance to get the vaccine was higher, leading to lower vaccination rates than what we had hoped for and a greater number of preventable deaths. And in communities of color where misinformation perhaps is um, uh, amplified because there are often more insular and lack health champions in their communities that will promote vaccines. This is shown in research over and over again, and certainly again borne out in COVID-19 vaccine research. We found that essentially a doubling of all of the concerning issues surrounding the vaccine and doubling preventable deaths in those communities. So I use the word vaccine hesitancy. I think we should define that. Vaccine acceptance rather falls along a continuum. And you can go from those on the right here of the screen that accept all vaccines. This is my mother-in-law. If I tell my mother-in-law to get a vaccine, she will absolutely get the vaccine without question because she thinks I'm a good doctor. On the other end of the spectrum are those who refuse all vaccines, including childhood vaccines. And these are sort of your anti-vax folks. But in the middle, we have a group of people who either delay or they refuse some but not all vaccines. We're not really sure why, or perhaps they refuse all vaccines, but they're not really anti-vax. They had childhood vaccines. They'll give their children vaccines, but maybe they're not getting, their annual flu shot or their COVID vaccination. We know these folks are out there in the wild. In the last month or two, I've been asking folks, are you getting the COVID vaccine and the flu vaccine? And I don't know if you do this in your clinical practice, but it's shocking how folks will either say none, both, one or the other, and they'll have very valid reasons for getting the flu but not the COVID, or the COVID but not the flu, and that's our folks in this vaccine hesitant group. And vaccine hesitancy, has been pervasive, since the vaccine was first introduced in 2021, and has gotten worse and worse. Our COVID vaccination rates, particularly for the boosters in the last two cycles, have been quite low. And, they've fallen across party lines. And certainly vaccine hesitancy, affects, anyone of any political clout. But we certainly have seen its effects more pronounced in certain political parties. So unvaccinated people in 2021 were 3 times more likely to be Republican than they were Democrat. And, that resulted in, a number of observations. Those residents who lived in Trump-won counties across the United States in 2020 were 3 times more likely to die from COVID. Now, this isn't causality. This is just associations, but, the research is certainly concerning. In the post-vaccine era, so after 2021, the death rate for folks from COVID-19 was 43% higher for Republicans, and that was even more so amplified in counties in Florida and in Ohio. So vaccine hesitancy and lower vaccination rates and greater numbers of death really did impact the pandemic. It prolonged it. Had we vaccinated more people earlier, there's a thought that the pandemic would have been shorter. It would have led to less variation, certainly, and the variants did prolong the pandemic. It created vaccine fatigue. So vaccine fatigue is, for folks who were not vaccinated, didn't get COVID right away. And then the longer they went on not getting COVID and not being vaccinated, they thought, well, I don't need to get vaccinated. I perhaps am one who doesn't get COVID. And that vaccine fatigue led to another subset of the population not being vaccinated, and again, prolonging the pandemic. And all of this led to great stress and anxiety amongst, the world's population, particularly in the United States, as we were all sheltering in place and continuing to have social distancing and other restrictions placed upon us. Now, who's at fault? So social media certainly is to blame, and I'm a big fan of social media, and I'll talk about that a little bit later in the talk. But social media is certainly culpable. About 50% of all misinformation, not just health misinformation, but misinformation, is found on social media platforms. And this is you wanted to illustrate. Joe Rogan had until quite recently the number one podcast on Spotify, and certainly did during the COVID vaccination years. And would routinely bring on controversial guests, purported physicians or scientists who would explain to his audience why the vaccine was, in fact, deadly, or perhaps that COVID didn't exist. And this led to a lot more young people not getting vaccinated, and again prolonging the pandemic and all sort of the other impacts that I had to say. And this is really important. This is called top-down misinformation. It comes from celebrities online, and it accounts for 20% of all misinformation, because most of our attention is placed on celebrities on social media, right? So you don't join X or Blue Sky to follow Dr. Dixon and myself. You follow it to follow, join to follow Beyonce, right, or Barack Obama, whoever your icon is. And these folks have great influence on the behaviors of the U.S. population, and certainly account for quite a bit of health misinformation themselves. Now, Joe Rogan, you can argue perhaps knew what he was doing, or at least suspected that he was bringing in some charlatans. And, that's where it crosses over from misinformation to disinformation. So disinformation is false or misleading information that is intended to spread harm, that's spread with malice. So if grandma knew that, in fact, there was no one eating dogs and cats on the streets of Springfield, but yet told you at dinner anyway to get you to change your vote, then that would have been disinformation and not misinformation, using our example from earlier. This, causes a lot of chaos for Americans, particularly around health misinformation, where it is really difficult to navigate what is correct health information, rather correct health information versus misinformation or disinformation. There's an information overload, or what we call an information epidemic, an infodemic. And the word infodemic is best defined by the World Health Organization. An infodemic, in their definition, is too much information, again, good or bad information, all taken together, overwhelming the end user, causing confusion, mistrust in public health officials and healthcare providers. And in terms of infectious disease, it lengthens outbreaks and pandemics, just as we saw with COVID-19 over the last several years. But we had a group of us who wrote a paper on the COVID-19 misinformation, infodemic in specific. And as I said earlier, we defined it as complex or contradictory information, again, about the origins of the virus and the treatments that were purported to be available, and the vaccine itself. So this leads to a psychiatric term called information overload. This is actually the DSM. Information overload is, the paradox of choice. So I like to say, to illustrate this, when I go to Whole Foods to buy ketchup, I get there and there's a lot of ketchup, and I just really want to find like Heinz, or if it's a bad day, some Hunt's ketchup, and I'll go home with my ketchup. But when you get to Whole Foods, next time you're there, look, there's like 25 organic ketchups to choose from. And I think, well, I should know which is the best ketchup and which of these organic brands is perhaps the best brand to bring home. And I study them, I look at the labels, and what do? I leave without any ketchup. This is the paradox of choice. And information overload absolutely is relevant during an infodemic. It decreases our ability to make decisions and choice. It increases our anxiety. I certainly feel terrible when I go home and explain to my family there is no ketchup because I was overwhelmed and unable to get the ketchup. It leads to depression amongst me and my family for not having ketchup, and it decreases our quality of life. Now, this is a trite example, but this is certainly parallels much of the anxiety that folks had during COVID-19 and the vaccination drive at the time. Then you have physicians who also spread misinformation, or I would argue disinformation. They have a medical degree, and their impact on society, particularly during the 2021 vaccine rollout, was significant. And if you remember, in the fall of 2021, the Federation of State Medical Boards started to come down on physicians who would spread misinformation, and that related to the vaccine. It also related to the use of the farcical treatments, hydroxychloroquine and such. And if you were using those medications in your practice, that was considered an egregious act of medical care, and not just malpractice, but the spread of misinformation in specific. If you were using ivermectin, you were spreading a false belief about the use of ivermectin, and that misinformation was getting physicians sanctioned or losing their license in certain states. It wasn't just the use of ivermectin as some sort of malpractice. It was instead the spread of misinformation that was getting physicians sanctioned. And there were really interesting websites. These still exist. This is no license for doctors. If you find a physician who's spreading mis or disinformation about a health-related topic, it doesn't just have to be COVID-19. You can go onto this website, do a search, find their license by state, and report them. So this is available to the public. And our previous Surgeon General, Vivek Murthy, had a campaign in 2021 in the summer where he acknowledged that health misinformation is a public health crisis, and had a really wonderful initiative at that time, which resulted in a great monograph. If you wanted to pull it, it's from July 2021. It has wonderful chapters on how researchers should be impacting misinformation in the United States, how educators can do so, how politicians can do so. It's a really useful resource, and again, he brings together our whole of our profession to try to fight this, and you can find that at coronavirus.gov still exists, and through the Surgeon General's website itself. All right. So our first question is, what is the impact of health misinformation? I think with the COVID example, we can all agree that misinformation has significant impact on human health. And with our example, we acknowledge vaccine hesitancy led to deaths and new variants and an infodemic that affected us all. All right, so if it's important, then we should be teaching our residents about it. So here's some best practices for addressing misinformation in the clinical setting. These are what I call 7 tips to teach residents, because we can talk about misinformation, but how do you address what is sort of an insidious and pervasive health problem is much more difficult. I have a colleague who's a lawyer who says it's the same. Misinformation is the same as putting toxic waste dumped from a factory into our water. It's insidious. You don't see it happening, but it does result in illness later on. And similarly, misinformation is pervasive. Our patients come in with all sorts of misinformation every single day on every single topic, and we're there to educate them, right? But sometimes their behavior for misinformation needs to be addressed in very specific ways. So here are 7 tips to teach residents and to role model in the clinical setting. We're going to use, again, COVID as an example, but these can be used for any health misinformation topic. So when speaking specifically about vaccines, research now shows that we should spend time only with patients who are deliberating vaccines or vaccine hesitant patients. So why is that? Gone are the arguments that you as a young 25-year-old healthy person should get their COVID vaccine, not because perhaps you at 25 may die, but maybe you'll bring COVID home to your grandmother who's living with you who's ill, and if she gets COVID, she would die, right? Or you want to get everyone in the neighborhood vaccinated so no one in the neighborhood can catch COVID. Those days are gone, and now it's, in fact, we have to just really focus on folks who are deliberating vaccines. The other important point is that folks who are refusing vaccines, the anti-vax folks, have fixed beliefs. So a fixed belief is a belief that is long-standing and really entrenched in someone's value system, and it can be caused by many different points of incidents in their lives or their study of certain topics. But once it's fixed, and it's very hard to unfix a fixed belief, and especially so in a 5 or 10-minute clinical encounter with someone. If you are an anti-vax American, you are probably anti-science, you are anti-society, you believe in individualism, you believe in freedoms in ways that perhaps others of us may not share that same definition, and you choose to exert those beliefs in certain ways, and in this particular way, when it comes to your health or your children's health, you refuse to have vaccines. It's very difficult to convince a person who doesn't give their children vaccines that they should take, in fact, the COVID vaccine in the 5 or 10-minute encounter that you have with them, or the flu vaccine, or whatever that might be. So that's not where you should teach your residents to spend their time. You should spend their time with folks who are still considering the vaccine. And that's important because you can use motivational interviewing with them, motivational interviewing that we've used for years with smoking cessation or folks with alcohol use disorder. And it's simple questions. Have you received other vaccines? If they say yes, they've had their childhood vaccine or they get their flu vaccine, it's as simple as saying, may I ask why not the COVID vaccine? Hearing folks out and then giving them information is much more likely to change their behavior than it is to change folks on either end of the vaccine spectrum. So, tip number two, you find these patients, you're asking them what they think, and you should, again, with motivational interviewing, engage them with empathy. And, I'll tell a brief story that when the vaccine was first rolled out in 2021, they were giving away coffee cards. To the coffee carts in our department, and the more patients who got vaccinated, got a chance for the coffee card. And I won the coffee card one week. I was very proud of myself because I was trying to get a lot of folks vaccinated. And there was a young man in his late 20s who was a PhD student at Stanford in electrical engineering. And he came in. I thought, this is easy. I'm getting my coffee card here. And I was like, do you want the vaccine? And he said no. And I was really surprised. It kind of struck me. And I asked him why not. He said, I just don't want it. And I was like, but why not? And he's like, I don't want it. And I'm like, but you are getting a PhD in electrical engineering at Stanford. Obviously, like you're a scientist, like obviously you want the vaccine, right? He's like, no. And that was really, the extent of our conversation. Went around and around in a circle, and he certainly did get vaccinated that day. But I was so surprised. Like, it just made logical sense to me as a scientist with my background, that another scientist would just simply agree that the vaccine was important. Now, this was in the very first months of the rollout, and I obviously have found this to be an interesting topic and have studied it differently. And I approach my patients quite differently now, and I would have approached him quite differently had I seen him months later. So, engaging patients with empathy, motivational interviewing is validating where your patient's coming from and trying to meet them halfway, right? So I understand why you're concerned about the vaccine and have not yet gotten it. May I share some information with you? Most patients will say yes to this question. They have come to the clinic or the emergency department because they want help. Now, they may not in the end agree with your opinion, but they did come to seek your opinion. Still, in the post-COVID world, we've as physicians and nurses, taken a little bit of hit in terms of our reputations. The social distancing and shelter in place and things that extended to our reputations, as for scientists writ large. But we are still amongst the most respected folks in society, again, in last year's study. And our patients come to get our opinion. So if you say, may I share some information with you, almost all patients are going to say yes. And then you give them the information, you let them make their own decisions, and thank them, acknowledge them, thank them for letting me share what I know, which I do with patients all of the time now. And it's a very different approach than I had before, and one that it's not a game or a trick. This is just really how I think patients should be approached by this. And in terms of vaccinations, I always end with we're open 24 hours, 7 days a week. If you don't want the vaccine now, come in at any time, and we'll give you the vaccine at triage, and we're happy to do so. And I don't know how many patients come back, but I would suspect somebody comes back. I would like to think that but keeping the door open and acknowledging their decision-making process may take time. You've allowed them to come back on their own terms. All right. So tip number three is to personalize the message. So let's go back to the 25-year-old who, doesn't want to get vaccinated despite, telling him that he'll save grandma upstairs. That worked in 2021. Lots and lots of young people got vaccinated because they were worried about their family members or those in the community. But research has shown, particularly in the last 18 months, that those folks have all been vaccinated. They don't exist anymore. So now we have people who are not motivated by that argument. So research is showing that we need to just talk about them as individuals with you statements. Let's focus on the vaccine, how the vaccine can help you, not how it can help your grandmother or your neighbor, how it can help you. You're healthy. I recognize this, but COVID can still make you sick. You statements. The vaccine can prevent you from getting seriously sick. You won't need to worry as much. And focusing on them as individual and using you statements and personalize the message will help them think about their decision, will help their decision making in ways that focus on what they value the most, which in this case is their own personal health and not that of those in their community. Tip four is to describe how misinformation happens. So, patients don't necessarily understand how they got their false or misleading information delivered to them. It may have been through family members or friends or the news or misreading something in popular press. But however it happened, and it takes some time to kind of explain to them, how they perhaps came to believe what they believed. And I think this really is elucidating for some patients. So some simple statements. I understand your worry about side effects. This will be again with the vaccine. The vaccine has been safely administered to half of the world's population. So you acknowledge that they have concerns, you follow it with some sort of a fact, and then you explain why they had their worries. So inevitably, some people will get sick from another illness who happen to have been vaccinated at the same time. It doesn't mean that your vaccine or their vaccine caused them to get sick. They just got sick at the time that they got vaccinated. It's not causality, it's association. And and point with vaccines, particularly this issue of causation versus association, is one that requires a little bit of time to tease out. But I think a lot of patients, if you spend time with them, explain to them, the difference is. I think they can get their head around then what misinformation is and how it happens. Alex, who I acknowledged in our paper earlier, published a really wonderful paper on learner-centered educational frameworks. And, we argue that this should be, the way that you create your classroom, rather, should be the same way that you create your clinic. So a safe learning environment for patients to explore what they, are learning with you. You should look at their own motivation and use statements for patients, motivational interviewing to make sure that patients are making decisions that are authentic to themselves for good reasons along their value system. Scaffolding and framing, giving them information and building upon that information. The vaccine is very safe, and lots of people got sick at the same time that they got the vaccine, but that was not, causation, that was association. And then social acceptability, acknowledging that we learn as social beings, and we learn within families and friends and other social networks that affect our learning. I had a young woman in late 2021 who was quite sick from COVID, and had a lot of comorbidities. And I asked why she wasn't vaccinated, and she said, because my father told us none of us were allowed to get the vaccine that lived in our house. And there's some socialization there that prevents anybody from really learning beyond that when they're just simply told they can't have the vaccine. All right, so here's a six-step method to debunking misinformation. So we've talked about sort of the motivations and how you might explain it, but here's actual scripting or words that you can teach your residents to use later. And again, these can be used with any example of misinformation, topics that'll show up in our emergency department. I'll continue with the vaccine just to illustrate. So the 6 steps are to state the misinformation once. You get to acknowledge what it is that they perhaps are misinformed about. Then you immediately follow it with a fact. Then you explain why folks once thought that the misinformation was in fact true, but now explain why we know it to be false. You'll explain why the alternative, in fact, is correct. And then you will close by stating the fact again. So they hear about the fact twice and they hear the misinformation statement once. So let me give you some scripting around that. So the misinformation statement that you might have encountered along the way was that the vaccine was made too quickly and it's unsafe. That was a very common piece of vaccine misinformation. The vaccine was made in an unsafe way. So you followed up with a simple statement that the vaccine actually is among the safest ever made. It is among the safest vaccines that have ever been made. And that's a simple statement of fact. And you can acknowledge, though, that some people were worried that testing was rushed, and that may have led to folks believing that it was unsafe. It was fascinating that the vaccine was available just 5-6 months after they started working on it. And it's important to know that the vaccine was actually tested in an appropriately large population. Just the vehicle, the mRNA vehicle, was tested for years prior to COVID. Just happened to have been tested in a large enough population that the actual vaccine itself, needed a little bit less time and less, total population to test them. And since it was developed, it's been safely given to half of the world's population. And it is, again, among the safest vaccines that were ever made. So you see the misinformation followed by a fact. You acknowledge why the misinformation was once believed. You acknowledge why now we know it to be false, and provide a statement about the alternative. And then, again, the fact is repeated. Okay, and the last tip 7, is to just incorporate, in this case, COVID vaccine, but whatever, health initiative you have into your routine healthcare. And this is a simple example. You are overdue for your COVID-19 booster, right? So this is, something that Epic will tell us all the time. I order boosters for all of my patients who are overdue. So it's very similar to, I get CT scans on such and such patients who have a negative X-ray, hip fracture, whatever, as routine practice for, and patients won't argue with that. If you give them the option, would you like to get a COVID vaccine today? Now there's, conversation between you and the patient, as if there's value in them not getting the vaccine, that there could be a yes or a no answer that would be acceptable to you. And if you just make it routine practice, then you sort of take away the value statement of what would be the answer that you don't want. So you simply say, you're overdue. I order vaccines in all my patients who are overdue. It's my routine practice. All right. So, what are best practices for addressing misinformation? To close our second question, I think this really is all about motivational interviewing, right? It's respecting your patients, it's listening to them, it's validating what they have come in believing. It's helping them understand why perhaps the misinformation is in fact misinformation by giving them facts and then letting them draw their own conclusions, informing folks, thanking them for their time, and hopefully opening the door for them to make whatever health decisions that you've recommended, at whatever time that they're most comfortable. All right, we've talked about why it's important. We've talked about a little bit of role modeling and tricks and tips you can use in the clinic. Now, I think this is really the core substance for why we're having a Cord Connects webinar today, and that's how to best support our residents in addressing this issue. Health misinformation has become a hot topic to research in the last several years, and it's certainly a point of advocacy for physicians online, and residents are certainly going to enter this space as well. So, there's some ways that we can help them do so in a professional and safe manner. So, from that article of Shang et al., we point out a couple of things. One, we have very little curriculum on this topic. If you do a lit search right now, there's not a simple toolbox for teaching emergency medicine residents how to do this. Curriculum is still in development. So if within your particular shop you want to create a series on misinformation, what it is, why it's important, how to address it, that's needed, because we don't really have a playbook to offer you right now. When you do decide whatever local training is most appropriate for your particular residency program, recognize that training the residents in a silo is probably not going to be sufficient, that our faculty themselves have never been trained on this topic. And if we are expecting them to role model good behavior for our residents, certainly we need to train them as well. So thinking about curriculum development, both for the residents and then faculty development for the faculty themselves. We do think that an important point of addressing misinformation is showing our residents how to do so at the bedside, and we just talked about that with all of our examples. But there's classroom education and there's bedside education that both are important when helping residents start to work in this space. I recognize that some residents are going to be tiptoeing into areas perhaps online and in other spaces for advocacy that might be misinterpreted by your institution or by prospective employers as to be overly political. We have to help educate those secondary audiences about why residents are doing what they're doing and helping them succeed. So, explaining to prospective employers what these scholarly interests are of your residents and why their approach has been supported by your department, working with institutions to change policies about how residents can interact online. I think many of our old social media policies, if you remember those from a decade ago when social media was just becoming a thing, all our hospitals and medical schools made up these social media policies. Many of them are antiquated right now. And in fact, our hospitals view our work online with patients and other social issues to be much more beneficial to the institution and its reputation and the health of our communities than perhaps they did when they were quite conservative in writing these social media policies over a decade ago. And helping institutions, I think, write policies that support residents is at this time where social media is sort of crossing over and blurring with health misinformation topics for physicians. Very, very important. And then last, it is helping residents enter an online space that can be difficult and political, and it's tough out there. And I think our residents are going from Instagram accounts with vacation photos to more professionalized uses of LinkedIn or X, if they're still on X and things, supporting them in professionalizing their online image is really important, and role modeling that, frankly, with our own online presence and use of that tool. Now, I'll acknowledge that as a group of professionals, there is a lot of hesitancy for physicians initially to dip their toe in the water, rather, when it comes to social media, and that's actually a well-recognized phenomenon called healthcare provider social media hesitancy, and it's a public health threat. It's when physicians do not use their platform, not their social media platform like LinkedIn or X, but their social platform, to educate the public about things that are important. And social media is a wonderful way to educate our communities and other patients writ large. And to not use that platform, by many in Surgeon General's office and others is itself a public health threat, that we're not educating our patients in the way that we want. But there are, real reasons to be hesitant at this time, and there are real barriers that we have to acknowledge. Folks who are physicians who are engaging online, do so, but really never see necessarily the outcome of much of the work that they do. It's difficult to point at your consistent use of LinkedIn and messaging, and then saying that patients are somehow receiving that information and behaving differently. So that's difficult to convince physicians to use the tool if they don't see the direct outcome, and that makes sense. There's plenty of physicians who've been harassed and bullied online. There's a January 2021 article, I believe it's 2021, from the Journal of General Internal Medicine that had a very simple study that showed the number of physicians who've been harassed online when working in spaces on more controversial issues, reproductive health care or gun safety. Of that group of folks they studied, half of the women who had left social media had left not only because they were harassed, but they were sexually harassed online. So this is, a real phenomenon, and it's leading to disengagement of a group of people who were once quite passionate about this topic. So recognizing that and sort of helping your residents, navigate that if they're working in a particularly, hot button issue is important. I use social media to talk about medical education. No one's harassing me online, but obviously our colleagues who are, in more political spaces are having to navigate this issue. And then obviously, institutions who perhaps are not as supportive, or institutions that don't train their staff and faculty on social media, cause a little bit more hesitancy. What you're doing right now, misinformation training and social media training, obviously are facilitators. Now, I'm going to acknowledge, for those of you who are familiar with me, you may know that I was a big proponent of social media for medical education for really the last decade. I've been researching and talking about it for quite a while, and this is my most recent post on Blue Sky and on Threads. I deleted my X account. It was my New Year's resolution. I did it on December 31st because I just simply couldn't support that platform anymore. And this was after a decade of using it, and many thousands of followers and lots of scholarship done around social media. So this was a personal decision that impacts where my academic work had been for the last decade, and I've decided that I'm going to refocus that effort now almost entirely on misinformation, and perhaps use these social media platforms a little bit differently now for a while. We'll see how long this is my use of these platforms, but it's certainly changing my interest in how social media affects our patients, and where perhaps my interest and effort should lie. But if you are going to enter the world of misinformation online, and helping your patients and community because of it, there are methods to combat online misinformation that are similar to the ones that you might use in clinic, but a little bit different. So here's a 5 steps. So we get 6 steps where the online process is a 5-step method, but quite similar. So you first identify and label misinformation. So, as we had from our clinic example, you just state what is misinformation. In this case, you're online, so you're going to tag it and identify that as misinformation. And then again, you're going to provide correct information. So just like providing the fact, following the misinformation with correct information. But in this case, you're unknown, right, to these quote unquote patients. The patients who came to see you in the emergency department, they know that you're a physician or you have some sort of credibility from the institution that you work at. But folks online have no idea who you are. So you need to reference a source and provide some validity to what you're saying. And again, you give them the correct information twice in whatever response that you have. And importantly, you respond immediately. So quite commonly, I'm sure all of us have been online and we see something that's clearly misinformation or perhaps disinformation. And how many of us just scroll past and do nothing? And in this case, when it comes to health misinformation, we need to respond immediately, because letting things fester online, just spreads that misinformation to a greater number of folks. And if you're going to be a public health advocate and intervene here, perhaps you should be doing it right away. So here's an example of why this is important. So this is Nicki Minaj, and Nicki Minaj back in fall of 2021, so vaccine rollout year, famously tweeted this. She said, "My cousin in Trinidad won't get the vaccine because his friend got it and became impotent. His testicles became swollen. His friend was weeks away from getting married, and now the girl called off the wedding. So just pray on it. Make sure you're comfortable with your decision and not bullied." Now, again, top-down misinformation, very, very important. If you're a young man in your 20s and you're following Nicki Minaj and you hear that your testicles are going to get swollen because of the vaccine, are you going to get the vaccine? No, you're not going to get the vaccine. So someone needs to stop and acknowledge what Nicki Minaj is doing and intervene. And God bless the Aussies, they did this. So a group down in Australia did exactly what I just described. They acknowledged that what Nicki had posted was, in fact, erroneous, and they posted actual facts here, and did so by juxtaposing her tweet with the correct information. So this was a very powerful response if you're going to have an example. Probably the only thing that I would change here is some of the wording. So it says common side effects and things that don't happen. I probably would have changed that simply to things that might happen versus things that don't happen. And that might have been the only way I could improve this tweet. But this was really powerful tweet. Here's another example that I really like. This comes from March of 2020. So we're right at the beginning of the pandemic, and there's much online about how to kill COVID, and we didn't really know how to do that. But there were some who were arguing that high concentrations of alcohol could do it. So here's Tito's vodka acknowledging some misinformation. Per the CDC, hand sanitizer, which is high alcohol content, needs to be at least 60% alcohol. And in fact, Tito's handmade vodka is only 40% alcohol. So therefore, it does not meet the current recommendation by the CDC to kill COVID. And they I hear a quote from the CDC, and they repeat the fact down at the bottom: Tito's handmade vodka is 40%, does not meet the current recommendation, and they put a source. This is exactly the 5-step method, perfectly demonstrated by whoever's running the Tito's vodka social media channel, right? So there's, whoops, where did we go there? There's a falsehood, so your misinformation, followed by a fact with an explanation, the facts repeated, and the reference is provided. This is like the textbook 5-step method. Similarly, we had a vaccine campaign at Stanford with some undergrads that I was working with. This was an Instagram post that similarly showed a falsehood about the COVID vaccine changing DNA, with facts and explanations and a reference. So John, just as it's supposed to be done. One other way to address misinformation online is not after the misinformation has been posted, but in fact before it has. So pre-bunking as opposed to debunking misinformation. And again, there's a method to doing this. When you're worried that misinformation is going to be spread on a topic, you instead spread the correct information first. And you might identify or acknowledge what misinformation may be out there before a patient or community member even sees it online. So if you see this, that is in fact false. And then again, here's the correct information, and here's why in fact it will be false when you see it. So here's the correct information. Here's the fact. So fact, warn about the myth, explain why it's a myth, fact again. So it's a 4-step method. All right, so I'm going to close with just some residency opportunities. So, certainly we need to come up with curricula and train our residents and train our faculty and role model best behaviors in the clinical space and change policies in our institutions and support our residents as they step into the online environment. But what can your residency do as a um, program, perhaps to address misinformation, through different projects? And I did a search not long ago about this, and this is kind of a wide open area for residency programs. There's not a ton published in this area, but I'll illustrate a few of them. Here's one from Boston, and in this particular um, project, residents launched an awareness campaign about health inequities during the early stages of COVID, and did so this with a Twitter campaign. Essentially, they were acknowledging that communities of color were getting different information than predominantly white communities, and that this was leading to different behaviors about social distancing and masking and things, and was leading to early death rates being different between the communities. So they did this in a Twitter campaign. The AMA had a monograph with highlighting several residency projects, and here's a few of them that we can acknowledge. This one's out of Yale. These residents in the first 6 months of the pandemic filmed 60 TikTok videos about COVID, and teaching about social distancing and hand washing and masking and things like that, and got 600,000 views in the first month that they put these TikToks up. So they spread quite quickly, and certainly had a big influence on those who viewed them. Here's one out of the University of Chicago that used WeChat. So WeChat being a very popular platform in Asia, they used WeChat to communicate with a group of Chinese-speaking patients in a community on the west side of Chicago, where they made a number of videos and health infographics, and interacted with this group of patients quite frequently, and engaged them over many months. Again, primarily about COVID and preventative measures. So, your residence program certainly can come together and do projects such as that, and I think there's a lot of opportunity, and there's some roadmaps for how to do that in these and some other publications that you can find online. So, how can we leverage social media and teach our residents, support our residents? It's much of what I just talked about. It's curriculum development, it's role modeling, both in the clinic and online, and advocacy for those who want to enter this space and research in this space. So I'll end there with a nice quote from that monograph I talked about, the July 2021 publication by Vivek Murphy. He says, limiting the spread of health misinformation is a moral and civic imperative that requires whole of society effort. Whole of society effort, it feels very compelling to me. If all the physicians in the United States addressed misinformation in similar ways, beyond COVID, and extending to other topics, if emergency physicians chose to do so for the topics that affect us most, gun safety and things, I think that we would have a great effect. So I like this concept of whole of society effort. So with that, I'll end there, and I'm happy to take some questions or have a discussion in the last few minutes about this topic. And I'm really grateful to Dr. McLean and Dr. Dixon for their invitation to speak today. Look at this. Cassandra's here, and Dave and Lisa. Oh my gosh. Andy's here. Nice to see you all. Some waves.
Thank you so much for this talk. This was obviously a very timely topic for the Cord Connects, and it was excellent. There are a lot of points that you made in the talk that, I mean, like it really just makes me like want to rush out and organize our residents and reach out on social media and everything. But one barrier that I anticipate a lot of people across the country would have is that they're at an institution that isn't as social media friendly, or that has a media relations team that really imposes some restrictions on their employees unless you go anon or semi-anon on social media. So have you encountered any issues with those institutional restrictions on what you can post and how, how they feel about being affiliated with you? And if so, how have you navigated those?
Yeah, so this is interesting. I think I'll answer it in two parts. So, when you think about initiative your residency program might do, you can imagine, let's see, you do I don't know, what did we do in medical school? We had carts in front of the supermarkets where we check people's blood pressure, or whatever those health issues are. This is no different, right? You don't necessarily have to label something as misinformation, and this is my initiative to change it. It's really educating the public, right? And I think if you can do that, maybe with a lot less political words than I used in this particular talk, you can get to the same end, right? You can address some issue of misinformation without necessarily saying it's misinformation. So in that case, I think our institutions writ large would be happy for us to do community engagement work. I think all of our hospitals want to engage with the community and would support an initiative like that. Perhaps in the background, a little bit more about the motivations for why you're doing it, but that outward facing initiative doesn't have to be that. But to answer your question in terms of my own personal experience, Stanford's kind of an interesting place, right? So there's a lot of Stanford folks online. There's a lot of us that show up on CNN in various ways talking about this, that, and the other thing. And it certainly happened in COVID. And there were physicians at Stanford who got a lot of heat early on in COVID for their beliefs about how we should be managing social distancing and others. Some of those folks are now assuming very high um, uh, posts in the new Trump administration, but it in 2020 had hundreds of Stanford physicians writing petitions against them. So it's an interesting institution to be at. What I appreciated most about that at the time is that while there were a lot of backlash to some physicians that perhaps didn't hold popular uh, opinions, the university still treated them as if they were university professors at a liberal arts institution, and they had the ability to have controversial discourse because that's what universities are for. And they had a run of it, but they perhaps didn't lose their jobs. Now, I preface that because quite recently I was in a documentary that's about to premiere in February on health misinformation. I appear in it for 2 minutes as like the doctor expert, right? In this otherwise lovely documentary about patient stories and things. And Stanford just reviewed the film and had me scrub all sorts of things to allow me to participate. In fact, I'm interviewed online with the little Stanford Medicine logo, and that was I was required to have that blurred. And I the 2 minutes I went back and listened to what I had said, and every line that I say in the 2.5 minutes is a fact or scientific fact from a journal article that I can produce, except for the line that when I walked to work early in the pandemic, I was in tears that I was going to get COVID and bring it home to my family. That's perhaps the only line that isn't substantiated in a journal article. So, I think that's the definition of moral injury, right? To go back years later and take a physician who was on the front lines, who was, crying on their way to work one day, and then tell them that they have to scrub the university's logo from their appearance in a film, when many of my colleagues go on CNN with the exact same background and say all sorts of stuff all of the time. So, to answer your question, institutions can behave very poorly, and I continue to, work it up the chain right now in the university as to who it is that, decided that this was a policy. Because I don't blame like the management folks that are non-physicians that work in the school of medicine or just doing their jobs, right? Like, this is the social media policy, this is what you're supposed to do, et cetera. And in the case of a film, you do this and this and this. But I'm trying to figure out who their boss is, honestly, Harry, because it is it is moral injury, right? To have gone through all of that, to speak as a scientist, and then it has to be scrubbed, the blurred rather, just on principle. It's really annoying. So your point is well taken, and it's actually quite personal in the last couple of months as I'm navigating that.
Thank you for that.
Yeah.
Do you feel like I unfortunately do a very strong impulse to just bury your head in the sand for the next 4 years and just try to survive
Yeah,
daily shifts.
kinda. I mean, this is me. And I'm on a personal journey right now. Professional. I'll tell you, William. Like, I mean, you knew that I used social media for a whole lot of reasons before, and I mean, we can argue that Twitter and X was getting kind of mucky and gross, this particularly in the last year, but there was still, I don't know, I still found value, right, in its use, and in the last couple months, I mean, I just my ability to uh to navigate the news. I mean, I've hardly watched the news in the last 2 months. I mean, obviously, everyone, I'm being very political right now, so I apologize for that. But I mean, I've had a tough time, even reading the newspaper, and have chosen to get rid of the apps I used to use I used Google News before, and it would had algorithms that drove me insane. So I'm picking different news apps that have less of that, and I chose to dump my X account for similar reasons. And I'm trying to channel my energy and my academic interest in this into a specific space of misinformation. And I feel like for the next couple of years, it's going to be an exercise in that for a while, and that's how I'm going to work through it. Right? It's my own sort of reaction to it, and I'm gonna it's intellectualization at its greatest. Right? That's how I'm going to handle this
I'm
this
calling
time
it
in my
my
life. Yeah,
my American countertransference.
that's right. That's right. Yes. Yes. I
All
believe
right.
we left the WHO yesterday, did we not?
Yeah.
I mean, it's a timely topic.
Um, Wonderful. Well, with that, I think we will call it here. Thank you all so much for coming. We have the next couple months here blocked out, so I look forward to more Cord Connects calls and enjoy the rest of your day.
Thank
Thanks for
you.
attending, everyone.
Thank you, Mike.
Thanks for coming, Lisa. Bye.
Good to see you, Mike. Thank you.
Yeah. Bye, Dave.